Hello, everybody. Dr. Bob here. Happy Easter. He is risen. A miracle happened this Easter, sort of. I spent some time on YouTube this morning, and I think I've grasped enough of the technology that I can do some productions now and show you my computer screen. I've been struggling with it all morning, so don't laugh too hard if I don't do too well. Now, I think I told you guys that I am a little late. I think I said within a couple weeks I would talk a little bit about insulin resistance and insulin sensitivity. Hugely important thing, and I'm going to spend a lot of time on it. But I was a little disappointed with how many views my advanced cardiovascular disease risk stratification video had, because I have more patients than views, and it worries me because it's really important for my patients to understand this, and anybody else that's paying attention to me. You really want to learn what that video has to say. It's long, I'm long-winded, I apologize, but look, I think I do a pretty good job of getting the point across to you guys, and if you'll pay attention and listen, you'll understand things better and can manage your own health better, maybe understand your doctor a little better, and be a little better at shared medical decision-making, which is what this is all about. So this lecture is to try to drive you back to that lecture, and I'm going to try to explain the whole vascular disease pathology in a little greater detail, with a little bit more emphasis on why the disease model is failing to identify the biggest risk to your health before it happens, which is the obstruction of arteries that are going to kill tissue in your body that is very important to your function. We got to figure it out before it happens, and we have to mitigate the events that drive this, and hopefully do so without the use of the disease model medication pharmaceutical industry. Not that that's not an important tool in the tool bag that we all have. Excuse me while I take a sip of my favorite Yogi, I think I'm saying that right, green tea, kombucha green tea, which is full of antioxidants pertinent to what we're talking about and quite tasty. A little bit of pure stevia, the P-U-Y-R-E version available at Walmart in there for taste. Okay, this particular slide is a great article. I've read it. It has a slide that I want to use. You see it down there in the figures in the bottom. I'm giving credit to this article because it's where I obtained this slide. I'm going to switch to that right now. And what you see is the progression of blood vessel disease as it occurs. Now, understand that to the left is a normal artery. And as life progresses and we're exposed to these risk factors at the bottom, and by the way, read those risk factors. They are all modifiable by your behavior. Okay, so increased energy intake, increased consumption of saturated and trans fats, smoking, the most inflammatory thing, one of the most inflammatory things you could ever do to your body, and decreased physical activity lead to the beginning insult, which we see endothelial cell injury and activation. So mechanical trauma, shear stress, infection, reactive oxygen species. And we start to see this little wall of the artery, this single layer we call the endothelium, becomes inflamed and gets fenestrated. The castle wall I talked about, if you listen to the previous lecture, now has a hole in it. Next, step 2, LDL oxidation. Now, LDL, as we recall, is the low density lipoprotein particle, one of the subfractions of the cholesterol that we know historically has been associated with increasing heart attack and stroke in population studies, where you see that as LDL cholesterol, as total cholesterol, as the coronary risk ratio goes up, or HDL, the protective one, goes down, there seems to be a linear relationship with increasing risk of heart attack and stroke. So these little bitty yellow particles manage to penetrate the wall and get behind the wall, and the beginning of the thickening of the wall of the artery starts to occur fairly early in life. Same processes, except now they throw in this omega-6, omega-3 ratio and salt, and decreased vitamins. Here again, all these things we can control. Remember, of course, supplements make no difference in life. Just ask anybody who's in the disease model. Only medications can help. But things like vitamins and antioxidants, like my yogi green tea, and the things that we eat, fruits and vegetables, full of these things, and supplements, which can enhance this. Supplementing with omega-3 fish oils to increase the omega-3 to omega-6 ratio instead of vice versa can all lead to less inflammation and improve this process. Decreasing energy intake, controlling our diet, which I'm going to teach you extensively about, but that's a long ways away. I need you to understand chronic disease, what we're trying to prevent first. And some of you guys are skipping the important stuff. So anyways, now these LDL particles get behind the wall. The next phase 3, macrophage infiltration. This is a big molecule that gobbles up stuff. I mean, a big cell, a white blood cell that gobbles up stuff. And they can squeeze through that fenestrated castle wall and start to eat that LDL and oxidize it. And then we see further thickening of the wall. And eventually the wall starts to develop smooth muscle proliferation, which is making the wall even thicker. Now you're getting this stiffened, thickened wall. This is leading towards more high blood pressure, which is this vicious cycle of increased risk that we talked a little bit about in the last lecture. And then we're moving right along, and the next thing you know, after now notice that the channel, the lumen we would call it in medicine, the diameter of the pipe that's feeding whatever important organ is to the right is getting narrower this whole time. Less blood flow. Less blood flow means less oxygen, less nutrients, less ability to carry on proper cell metabolism to whatever organ it's feeding. And we see that channel's getting narrower. But what is the event that causes the typical end organ damage, the death of that tissue? It's called thrombosis. That plaque, which is what we're talking about, that thick yellow stuff that's getting larger and larger to the right, can rupture. And when it ruptures, it creates a cascade of events that causes the clotting system to form a thrombosis, a thrombus, okay? This is the event that we see most of the time causing heart attacks and strokes, which is going to get about 60% of us, folks. So let's figure it out, okay? Decrease energy intake, improve your inflammatory balance through a high omega-3 to omega-6 ratio. That's all nutrition. Watch the saturated fat and trans fat intake. Eat a healthy diet, maybe supplement. That's going to be the last thing I talk about, but I think supplements are important. Definitely don't smoke, and get that physical activity up. All right, so you understand the process. We develop thickening of the wall. It's inflamed. It's got holes in it. It ruptures. There's a clot. The clot blocks off blood flow. What's downstream dies. This is what we're trying to avoid. Now, here's where the failure of the disease model. Most of you guys are sitting around just waiting for the first sign of end organ damage to start the investigation. And the disease model will kick right in. It'll cover all your expenses right once that happens, because there's a lot of players getting rich off of that model, okay? And if that's the one you want, have at it. It's not going to work out to your advantage. But I want you to understand something important. And for that reason, I'm going to take you to another article. This is an article from the Journal of Circulation. It's actually a review article of several other articles that looked at heart arteries and heart attack. And I'm going to go to one of my slide presentations on chronic disease. This is going to take me a little bit because I got to stop the share and then try again. So give me a minute here and let's see if I can do it right, and be patient with me. Here we go. All right. I see my slideshow, please. And new share. Okay, I'm having trouble. Oh, I did it wrong. Hang on. Got it. Here we go. Share. Hallelujah. Wrong slide, although that is a nice slide that sort of talks about what we talk about, stable versus unstable lesions. And it is nice to see some of the things that can help stabilize the plaque to make it less likely to rupture. And a lot of those things are in my regular life, other than I don't take a statin. All right, this is the important slide here. Now we got to spend a little time on this, okay? And I said I wasn't going to go too long, so we'll see how I do. Okay, so you see 4 studies there to the left of the graph: Ambrose, Little, Nabioshi, and Garud, and I might have botched them. And if you look at the y-axis on the left, it's MI, which stands for myocardial infarction patients. And so one of the first study had 20 something in it, and the second study had 40 something in it, and the third study had right about 40 in it, and the fourth study had about 90. And then collectively to the right, we see the 200 patients if you added all these studies together. And the graph represents 3 different levels of lesions that were found at the time of heart attack and the coronary artery catheterization and treatment, okay, of these heart attacks. So what happens if you come into the ER and I see you and you have a heart attack? Well, with any luck, I either give you a thrombolytic, which is a chemical that will break down that thrombus and open the artery back up and restore blood flow really quick. Or if you're really lucky, you're at a facility that has a cardiologist and they whisk you off to the coronary artery catheterization lab. They stick a catheter nowadays in the radial artery because the technology is getting smaller and better, run it up into your heart, squirt the arteries, look for the blockage, suck the clot out, and then put a thing called a stent in to open the artery and restore blood flow to the heart. But it's the clot that did it, okay? And in this study, in these 4 studies, they measured the percentage of blockage. In medical terminology, we call that stenosis in these arteries that occurred in these 200 people that had heart attacks, okay? Now, it's pretty obvious that almost 70% collectively in these 200 patients, 68%, were in blood vessels that were blocked less than 50% at the time that that artery ruptured and thrombosed and caused a heart attack. Remember the previous slide, and we were narrowing. So only halfway thinned. Looks like another 18%, 50 to 70%. And only 14% of these heart attacks occurred in an artery that was more narrow than 70%. What does it mean? Who cares? All right, I care. You should care. You know why? Because you don't get symptomatic from having a blocked artery until it's over 70% blocked. In other words, 86% of these patients would have likely passed a stress test at the time right before their heart attack. So the vast majority of people running around with coronary artery disease are waiting for the heart attack. Now, considering 25% of heart attacks result in sudden death, oops, too late. Go back and listen to the other lecture. I teach you about a more personalized way to risk stratify you for whether or not you are likely to have this process going on. I wrestle in every patient. Do you take an aspirin? Aspirin reduces your risk of thrombosis if you rupture one of these. But science has shown if you put everybody on aspirin, you get more bleeding problems than you solve heart attacks. So you have to be properly risk stratifying before you assign people to aspirin therapy. Statins also stabilize plaques, in addition to lowering LDL cholesterol, which probably is a lesser benefit. So here's the problem. Most of you are waiting around for symptoms of angina greater than 70% stenosis, and more than half of you are going to have the heart attack before that ever happens. And even if you have some weird chest pain and go to the ER and rule out for a heart attack, but then get stress test, when you pass that stress test, it doesn't mean you have coronary artery disease. That's why I got a coronary artery angiogram that shows that it's negative. That's why we look at carotid arteries to see if there's evidence of thickening to suggest that this is happening, and that all these things play together, including your inflammatory markers, which tell me if you're at risk. I'm running a plaque test on myself right now with my upcoming labs. I haven't done that because I've never had an elevated CRP, and I lead a pretty plaque stabilizing life, which I'm going to teach you about when we get to lifestyle. Okay, go back and watch the video. God bless. Happy Easter. Get some exercise. Start eating right. Get down to ideal body weight. I'm going to work hard on that when we get to nutrition. And just stick with me. I'll get to insulin sensitivity. I hope you understood what I said here. If you have questions, feel free to email me.